Welcome back. I hope all of you are keeping safe and taking good care of yourself and your families and people around. Let's continue with our discussion. In the previous session, in the previous talk, we had looked at scientific temper. And we had looked at the power of observation, the ability to question, and the ability to listen as some of the key elements to improve scientific temper, the key elements of scientific temper. We looked at scientific temper as being an important part of the entire research process, sort of like the foundational bedrock upon which research thrives. Now, it's one thing to say that we need to have a good power of observation. It's a skill that we probably are born with, the power to observe, but it's a skill that has to be enhanced. And we need to look at how we can enhance the power of observation. Life is dynamic. Life keeps evolving. Things keep evolving. And the power of observation also will evolve. And we need to see how we can make sure that it's evolving on a constant basis. We also need to see what should we observe. When we say that it's important to observe, what exactly must we observe? And how do we transfer this knowledge to the medical student? Whether at the undergraduate level or at the postgraduate level, how do we transfer this knowledge to the medical student so that they can enhance and build their powers of observation? And this is something that the medical curriculum needs to look at. Is it something that's just intuitively taught as everyone has it and find your way to improve it? Is it something that is actively worked upon? Does the medical curriculum encourage, motivate, and actually work on improving the powers of observation of each person that passes through that curriculum? Now, to a certain extent, you can say that yes, it happens as part of the case discussions, as part of the case presentations, the workup of a case, which, if you break it down into its core components, involves the observation of certain phenomena by the learner, the presentation of what the learner has observed, the dissection and discussion around that by the peers as well as by the teaching faculty, and arriving at a conclusion, an interpretation and a conclusion, where the whole set of observations is taken, it's dissected, it's looked at, it's placed within context, fit into a pattern, outliers or things that don't stand within that pattern are identified, and you work through that. So there is a process that's actually happening that's looking at the powers of observation. Now, is that process sufficient enough? Is something that we need to look at carefully. Does the process confine itself to finding out or the elucidation of clinical signs and symptoms? Does the process involve the observation of the person, not just the signs and symptoms, not just the disease that the person has come with or the complaints that the person has come with, but placing all of that within an ecosystem of the person as a whole, and from where that person has come, the environment around that person. Is that a skill? Is that an observational skill that we can teach? Is that an observational skill that we do teach? Is it important? Let's look at that from the perspective of, let's say, even the control of tuberculosis. And within a controlled environment, like a hospital outpatient department, we identify based on the complaints and the physical examination, chest auscultation, and other examination of other systems of the body, physical as well as based on the laboratory and other systems that complement the physical examination. We identify the person as having tuberculosis. We identify the systems that are required, and we start medication and management. Now, within that process, we also tend, more often than not, find dropouts, failure to comply with medications, non-adherence. And as a result, we find that the ability to manage that particular disease diminishes or is reduced. And what we're seeing at play here is the interaction of the environment around the person, the external environment of the person with our regimes of management to target a particular set of conditions or symptoms or systems within that person. Which raises an important question. Does the ability to treat a particular condition, to manage a particular sign or symptom, is that influenced, or how much of that is influenced by the external environment? The internal environment of the person itself in terms of the person's acceptance of the condition, willingness to take treatment, and the external environment that drives a lot of those internal decision processes. The external environment also makes sure or has a role to play in whether the person can afford these kind of medications, whether the person can afford to continue with the medications, whether the person can afford to come back or will come back for follow-up, and a whole set of conditions. And if you treat tuberculosis and you go back to the same situation where you were in before, let us say an overcrowded, malnourished, undernourished situation, with a lot of potential for reinfection in the external environment, beyond the immediate short-term control of that particular disease, are we really managing the disease in the long term? So when we say that we want to improve the powers of observation, and when we say that we are presenting or we are looking at managing a disease or a condition, can we really discount? Can we really afford not to make an observation about the possible external environment of the person? Can we afford not to factor in those factors when we consider the line of management? When we consider the possibility of the person returning or not returning for follow-up, not adhering to medications, not adhering to the recommended practice of management. So then the question is, even within the framework of what is ideal for a particular disease, is there adaptability that is built or customized to each person, that person's internal environment balanced with that person's external environment? It's an important question to think of. And it's important to bring this, I'm bringing this into the conversation because it's important to have these factors built in as you are observing what's happening. And I'm talking from a healthcare perspective, what's happening in that particular person who is in front of you. Too often that not, medicine has become segmented into specialties. And we have a specialized look at systems, organ systems, that sometimes may not really consider what's happening around or the effects of working on one system. What's the effects of working in one system on the other systems of the body? I'm not saying that we are not considering. I'm saying that the particular consideration of the other systems of the body can sometimes get submerged as we focus on managing one particular system of the body. And If we add on to that a lack of consideration of the external environment, then the potential for whatever line of management that we're doing actually reduces. So when we say that powers of observation, do we then limit the powers of observation to the complaints that the person is? We take a history. We go based on the complaints and the history into different directions. There is a process that's happening on. I'm trying to think further on that. I'm not saying that it does not happen. There's a process that's happening, but I'm trying to think further on. Do we actually look at observing the person as they come? Do we see the person and the environment? Do we look at the possible relations that exist around the person, the environment, the whole environment that can influence how this particular medication or therapeutic intervention, whatever, works on the person? Or is our observation limited to this particular condition, this particular intervention, and only that? Are these considerations important? Well, it looks like it's a lot of consideration, additional consideration. Do we really need to look at that? Well, when we are looking at the effectiveness of an intervention, we need to be looking at factors that actually impact on the effectiveness of that intervention. Factors that can either make it more beneficial, factors that can be harmful or reduce the effectiveness. And ultimately, we need to realize that even though we are treating a condition or treating a sign, the entire treatment is on the person. And the person is not isolated from the external environment that the person comes from. And that external environment can influence the mind and can influence the mind-body interactions. And so if we want our medications, if we want our management strategies to be more effective, we need to be thinking of the whole around that person. So can that be improved? Is there a way to improve that? And if we consider the way that healthcare is being provided now, where it's mainly a hospital-based, wherever the hospital is located, a hospital-based approach, does the student get a chance to actually improve these external factors, the powers to observe the external factors when they are limiting their interactions to patients only within a department setting, an outpatient setting, an inpatient setting, a hospital setting? Does it really help to improve their scientific temper? Does it really broaden their horizons? Does it really give the opportunity to think of a whole set of other factors that can impact and influence the effectiveness of what you're doing? So you can see the connect coming here, that when we are expanding on the powers of observation, the range of questions that we get also increases. When we expand on the range of questions, the range of answers that we get is going to increase. And some of those might be solutions that are useful. Some of those might be solutions that are not useful, but you're expanding on the range of questions and you're expanding on the range of possible solutions. If we expand our powers of observation. To take that into the realm of teaching or medical curriculum, teaching or medical curriculum, as an example, if we use imaging as an example, does the exploration of, say, 100 images of a chest CT, let us say, or an MRI, give you better information when you look at the 100 images in isolation and you look at specific parts and you grade those specific parts and you're learning that. As opposed to interacting with the person from whom this image is, or interacting with the patient and working on the background clinical things that are happening. Does it give a better picture when you are trying to interpret this particular image? The same happens with a microbiological specimen, with a biochemical specimen sample, where we are, or even a pathology, histopathology or a pathology, where the interaction with the patient actually helps. Will it help to improve your interpretation of the sample that you're assessing? Does that interaction, that knowledge actually help you to start looking at the sample that's being given to you for an assessment in a better light, in a more meaningful light? And would that lead to you picking up, based on the clues that you have from the external environment, things that otherwise may not have been picked up? It can be they're picking up more abnormal things. It can be that you're saying that something that might be abnormal in a situation is now normal given the external environment of that person. So there is an interpretation play there. And you're now using a larger set of information points to make that interpretation, which comes from an expanded power of observation. Let us say a clinical student, resident or postgraduate student, or even an undergraduate student, looking at the person, doing a physical examination of the person, history, eliciting signs, symptoms, doing some basic tests as part of the physical exam, and then going back and visiting the samples, the histopathology samples, microbiology samples, the biochemical samples, going and seeing those with all this background information, even if it's an X-ray image, it's a CT or an MRI image or histopathology or whatever. Does it improve the ability to interpret that? Does it improve the ability to make that connection between the samples that you're seeing, between the signs that you're seeing, and the person as a whole? So you see it play both ways, where the person is not a basket of signs and symptoms. The samples are not material taken from somewhere and kept seen in isolation. You're trying to connect all of that into a single composite person and play on the interpretation there, taking all those things into account. The key question of this long-winded sort of illustration, where I want to actually read to is, what do we observe when we see a patient? And it's an important question to reflect upon. Do we observe the clinical signs and symptoms, and do we manage that? Do we observe the clinical signs and symptoms within a person and manage the clinical signs and symptoms and the person? Do we observe the clinical signs and symptoms and the person and the environment from which that person has come from and might most possibly go back? And do we try to manage the signs and symptoms, the person, and the external environment? Keeping all of that together, do we try to create a management plan that can work for that particular person for more optimal results? What is it that we observe now? And you can see the interplay that comes in. I said this a little while back. earlier in the talk, that as the information points that we observe increase, it's not going to increase more confusion unless we bring in an element of chaotic look into it. We're going to increase the number of questions that come. And if you keep your questions targeted, you're going to increase the number of solutions that can improve the management or outcomes for that particular person. So, from a research, healthcare research, since our key concept of this series is healthcare research in India. From the viewpoint of healthcare research in India, if we look at it, we find that most questions are related to a narrow confines within the narrow walls of particular constellations of signs and symptoms, disease entities, systems, a little bit expansion into the person as a whole. Not so much into the mental health, mental aspects of the person or the psychological aspects of the person, more on the physical, structural, functional, anatomical, physiological, pathological aspects of the person. The mind and the psychological aspects are not so well studied. The effects in terms of quality of life, in terms of stress, anxiety, depression, other mental health effects are not again so well studied. The effects on the economics of managing the disease for that person, from the perspective of the society, community, the person, the healthcare provider. Again, with an understanding of what does effectiveness mean, what does utility mean, defining those perspectives. Again, it's not well studied. There's plenty of scope. I'm not saying that nothing is being done. There are a lot of things that are being done. What I'm trying to say is that the potential, the possibility of doing a lot more things, finding out a lot more things that can help improve the life of this primary stakeholder, the person in front of us seeking care. Possibilities are endless, and we have not really tapped into those possibilities. The interplay of what happens within a controlled clinical setting, taking those results, transplanting that into a less controlled community setting where the person is at their home, and then trying to see how it works and what can improve that is again a gray area that has to be looked at. Now we can step back and say that, well, that is that really the purview of medicine, of healthcare? Isn't that something to do with socio-developmental indices? The development sector, the social sector, the environmental platforms, isn't that something different? Is that really part of healthcare? And that's something I want you to think of. Can we manage a disease without understanding the social, developmental, economic, societal, environmental, and even the political environment around the person, around the management of that particular disease? Will our understanding of these factors, will our factoring of these factors, will our observation of these factors, question of these factors, listening and understanding the answers on these factors help us to further improve the very dismal health indices that we have in this country? I don't have the answers for it. I don't claim to be an expert on it. I don't claim that I have the answers for it. But it's a thought that I want to place out there. Should the way we teach healthcare now, the medical curriculum, is that really helping those who are learning it, the learners, to go out and find solutions and practice solutions within communities without being judgmental, not defensive, not looking to find out mistakes. I'm coming at this from the perspective of we have been following a particular system over several decades, a system of education, system of transferring of medical curriculum for several decades. We have so many medical colleges. We have increased the number of medical colleges. Many districts have more than one medical college. In the private sector, in the non-governmental sector, in the government sector, we have a lot of students coming out. And we do say that we pick through our entrance exams and other modes, the ones who are very intelligent or very smart. So we are taking a pool of students who are capable. And they're passing through this mill. They're coming out as doctors. They're going to practice. Is that whole process translating into better health indices? Has that translated into better health indices for our country? I'm not discounting the vast strides that we have made in terms of neonatal mortality, infant mortality, maternal mortality in many diseases. I'm not discounting that. But I'm asking, has this whole process helped us to achieve our fullest potential? Is it time to revisit this process and see whether it's meeting its core requirement, which is improving the health or sustaining the well-being of our communities? And so, for a medical student in whichever stream, at the undergraduate or postgraduate level, the power to observe is a skill that has to be honed, that has to be refined, that has to be constantly worked upon to understand what's happening in the now and to be able to see what might happen in the future. I mean, that happens to be able to think on their feet and adapt. Think over this. Can our study of medicine, without looking at the factors, the underlying factors that drive the whole process of healing, of seeking care, decision making, from the environmental factors, social factors, political factors, economic factors, cultural factors, the whole set of external factors, developmental factors, equity, all those things. Can a narrow silo of disease management, signs and symptoms, control of this, help? Or should we be expanding our observations and our ability to change the way we practice? That's a question that I would like to leave you with. Feel free to think over, feel free to let me know your comments. As I said, I'm not an expert in this. I don't have any easy answers on this, and it's something that I'm placing out there for you to think over, as much as I will keep thinking on this on the line. Does the current medical curriculum actually encourage a more expansive, a more broader, a more deeper framework for healthcare research that can actually translate to better outcomes for the primary stakeholders, the communities that we serve? And as we do that, I will leave you with another question, which I'll probably come back to in one of the subsequent talks. What is the accountability? What is the responsibility of the medical colleges with respect to the health of the communities in the areas, the surrounding areas where they are situated? It links with my point about the power of observation. Can the medical PG or the medical student who is honed or who is training or who is honing or refining their skills within a controlled environment, will they be able to adapt within a less controlled community environment unless they actually go out there and try to refine and assess their skills within the community setting? Is there a real mechanism for that interaction to happen? So a few questions for you to think over, a few questions for me also to think over. Stay safe, be happy, put on your thinking hats, and we'll meet again next Sunday as we walk down further along this path. Thank you so much.